Hello everyone, welcome to the psychiatry module and starting with depression. So there are a lot of different medications that are classified as antidepressants on the market, and antidepressant use as a whole makes up the largest amount of drugs within the psychiatric spectrum. They're used not just for depression, for other diseases as well, but they are all classified as antidepressants and were originally studied as antidepressants. So we'll talk about a number of them. They're all to certain degrees commonly used, with the exception of a couple of the older ones. For treating depression, it is tricky to treat a tricky disease to treat, and I'll show you some more algorithms and things at the end. But essentially, about 1/3 of patients will experience remission after the first round of treatment, and then it kind of get diminishing returns after that. About 30% of patients will have some degree of relapse. It's a pretty complicated disease. We understand some basics of the pharmacology and pathophysiology, but there's a lot, I think, that is a little bit unknown as far as what factors go into why somebody suffers from depression. It's not a quick fix, which is probably one of the most challenging aspects, and this isn't alone with depression. It's most mental health diseases have the same problem where we don't really have a way to quickly correct the imbalance or whatever it might be. It takes a while for brain chemistry to remodel enough to get used to whatever neurotransmitters we're trying to manipulate. So usually for depression, for example, you're looking at a couple of weeks at a minimum, but usually about 4, even up to 6 weeks of treatment before you might see the results or consider changing a dose or something like that. There isn't any bridge, whereas every other disease in mental health, we pretty much have something that'll work relatively quickly. It's not a good long-term solution. For example, like somebody's having a panic attack, we can give them a benzodiazepine. We don't want them on benzodiazepines chronically for anxiety, but it works in the short term. There's nothing really for depression that works like that, unfortunately. There are some trials for ketamine and another drug called S-ketamine, to give to people in the short term to help them bridge to an SSRI. You might have heard of ketamine clinics or things like that. This is a little bit wild west science. There's not a lot of good evidence to support ketamine use. We don't do it at my hospital. But as more evidence emerges, that there may be some validity to it. I think right now it's just quite early. So anyway, depression's super common across basically any different ethnic differences or socioeconomic status. It affects large amounts of people throughout the world. It's likely very underdiagnosed, as well as being, if we look at the number of people treated for it, it seems a lot, but there's likely a lot of people that go undiagnosed as well. There's also a pretty heavy social stigma with having depression, especially in this country. Unfortunately, mental health and mental illness comes with a heavy stigma, and so doing our best as healthcare professionals to work around that and to explain the treatment and the options and the diseases in ways that are approaching from a scientific perspective, I think, can help. Okay, so what exactly is depression? Depression is usually described as unipolar major depression, differing from, of course, bipolar disorders. So a person has to have suffered at least one major depressive episode and has no history of mania or hypomania, and these are the defined criteria for a depressed episode, lasting 2 weeks with 5 or more of the following symptoms. So you can see some of these are a little bit different. So sleep can increase or decrease, appetite can increase or decrease. So there's a lot of different presentations of depression that can be all over the spectrum, but meeting some of these, the certain criteria would be what the DSM-5 would say is depression. Just because I like epidemiology stats, here's some incidences of depression. We're a little bit lower in the Midwest than other places, upper Midwest. That's kind of interesting. Demographics as well. You can see that here. Technically, women have slightly higher rates of depression, but it's close, but similar rates. And there's also postpartum in there too, which affects obviously women, which can kind of skew the statistics a little bit that way too. But otherwise, it's definitely there's lots of people in every different demographic group that are going to have depression. And just, I think we think about other diseases. I've talked a lot about things like stroke and diabetes, or like diabetes and blood pressure leading to things like strokes and heart attacks, and how people get put in ICU, and that's a heavy burden on the healthcare system. But we don't talk about really, and I don't think we talk about enough in society, is the burden that mental health conditions place on some of the intangible things that you might not think about. So the costs, of course, there's hospitalization costs, like if somebody attempts suicide, or if somebody is depressed enough where they're thinking about attempting suicide, there's a hospitalization cost. But you also have decreased productivity in the workplace. You have, which is absenteeism. So basically, you're showing up to work, but you really aren't doing much, and that, of course, can put you at risk for losing your job as well. That's presenteeism, excuse me. But basically, there's sick calls and things like that associated with this too that end up causing a substantial amount of financial impact that I think people don't necessarily always think about with associating mental illness with kind of the burden on society. So treating it not only for the patient, but also for that aspect is also important. So we want to get people into remission if possible. It's not completely possible with all patients, but that's the goal. We want to restore whatever their daily functioning is, preventing other comorbidities. So the big thing to prevent here is death by suicide. That's going to be I'm assuming there's no other major comorbidities in the patient's life going on. That's going to be the largest risk factor for patients in untreated depression. Other things as well to mitigate their symptoms if they aren't being treated correctly, things like binge eating or turning to different types of drugs of abuse to self-medicate that way. That can take a toll over time as well. Patience is the big deal. I said this again, but really, again, it's important to mention that patients have to be able to understand that it's not a quick fix. We have to take our time with this. And it's frustrating for us as healthcare professionals too to see these patients try drugs that might not work. And I've talked to lots of mental health an area I've worked in quite a bit over the years, and I've done lots of inpatient, outpatient education classes and things like that. And it's one theme that comes up quite a bit is people talking about, oh man, it just took me so long to get the right combination of medications, but once I got there, it's night and day difference. But man, it took me years to get there, and that's not uncommon. And it's unfortunate that we don't have kind of that key that tells us exactly what we should be doing. And otherwise, it's just a lot of trial and error. I'll talk kind of about how you start people and things like that. But at the end of the day, again, there's a lot of trial and error and combination to get patients on the right combination of medications that's going to work for them. Now, here's just my joke. Here's a depressed stormtrooper. Kind of missed his opportunity there. And then cat joke. Cat no longer dulls the pain. Okay. Jokes aren't as funny when you're doing a lecture recorded from your closet. All right. SSRIs are the most common antidepressants on the market. They're a somewhat, I say newer class because they are maybe slightly newer class, but they are the major component and core of depression treatment. So SSRIs are first line for major depression, general anxiety disorder, obsessive compulsive disorder. So they kind of encompass a number of different mental health conditions. They are generally fairly well tolerated. They're very safe. And the nice thing is, if you want to look at this as a nice thing, is that if somebody overdoses on these intentionally, it's very hard to die from an SSRI overdose alone. People are probably just going to get a little sleepy. That's probably about it. Or feel pretty sick, but that's it. They're not likely going to cause a fatality by doing that. Good side effect profiles overall. Again, most people tolerate them well. There are different nuances, and we'll talk about those here in a second. So you may switch from one agent to another. You don't need to retitrate. So basically look at kind of like, well, are they at a low dose, a middle dose, or a high dose of this drug? And let's just put them on a middle dose, a low dose, or a high dose of the next drug and see if that works. You don't need to do what's called a cross taper, where you have to taper somebody off slowly of a medication while you ramp the other one up. Patients may respond well to one and poorly to another. So if you do treat somebody with an SSRI, it's really important to know that you aren't ruling out a class of drugs if one of them doesn't work. It's very common actually for patients, maybe if you even look at it a different way, if you say, well, the patients, maybe they all do kind of the same thing as far as an effect goes, but the patient might have a substantially different side effect with certain ones and tolerate other ones quite a bit better. And that makes a world of difference as well. Oops. The mechanism of SSRIs, so what they're doing is exactly what the name is. So they're serotonin reuptake inhibitors. And what that means is that there are neurons in the brain that produce serotonin, and they release serotonin into the synapse, and the receiving neuron picks it up on their receptors. And then there's these reuptake channels. I kind of think of it like the body's recycling. The serotonin goes through the reuptake channel, and you end up recycling it into. Now, if you block this reuptake, so here's an example with Prozac, or fluoxetine is the generic name of that, blocking this here, you end up with more serotonin available in the synapse. Now, over time, these receptors that maybe were getting underutilized in a patient with depression now get more heavily utilized, which increases neuronal activity in that particular part of the brain, which is thought to affect mood. That's the underlying basics behind treating depression, and that's the underlying explanation behind why we think there's a pathophysiologic connection between a serotonin deficiency and depressive symptoms. Now, is that the only thing? Again, we don't know for sure what else all is involved with depression, but we do know that there's a pretty strong link between this serotonin thing, and that's likely because of the drugs, because these drugs were developed, I think, actually for other reasons. I can't remember what they were originally designed for, but anyway, investigational use into serotonin agents with serotonergic activity in the central nervous system tends to improve depressive symptoms. Therefore, we kind of reverse engineer the pathophysiology and say, well, there must be some issue with serotonin. And so then that's where the speculation and theories come from. Over time, one other thing I'll add is that this diagram doesn't show is that after a while, the brain gets used to having more serotonin, or these neurons get used to having more serotonin available. They'll actually build more receptors, and they can interact more efficiently with the serotonin. That is why it's thought that these drugs take a long time to work, because for the brain to get used to this increase in neurotransmitter and build these new receptors, it can take weeks to do that, because you have to build these new proteins and things like that. And to get that done on a scale that's substantial enough to affect mood takes time. And so that's one of the reasons why people think that SSRIs take several weeks. And actually, basically, you could extrapolate that to any type of medication that's modulating neurotransmitters. It's going to take time to get to that point where you have a working medication. SSRI class side effects. So as far as a class goes, there are some similarities between them. So GI disturbances are probably the most variable across the board, I would say. Some don't really have any. I would say as a whole, they kind of trend anticholinergic, but lightly. It's not like, taking a dose of Benadryl. So for example, sertraline as a medication causes a fair amount of diarrhea, which is a common side effect with that one. However, something like citalopram or S-citalopram, those ones tend to be a little bit more anticholinergic, so might even constipate people a little bit. So GI symptoms, while I put it under a class side effect, they can all affect the GI tract a little bit. They aren't all equal, so keep that in mind. But the one thing to remember is that sertraline is kind of notorious for causing diarrhea. Sexual dysfunction and decreased libido is an across-the-board side effect with SSRIs, and it's likely their biggest drawback. And men and women will report this. Incidence is about 30%, so it's probably going to be the biggest complaint. And by far, again, doing classes with people and talking to people about their medications, by far one of the biggest comments I've heard about these drugs is that, there's kind of two groups of people that'll talk about this. People are like, well, at this point, I'm in the hospital. I was suicidal. I really just want to get my life back on track. I don't care if I'm functioning sexually or not. There's other people that once they kind of get to that point, they're like, this isn't really working for me. What can I do? So that's been a big problem, is that, you have somebody who might respond really well from a mental health perspective with an SSRI, but their, libido is gone. And so that's a way we have to balance, like, how do we keep the benefits of the drug intact from mental health while restoring your daily life expectancies of things you want to be able to function in. And so that's a big question mark with SSRIs, and something we'll talk about here in a second. How do we combat that? Somnolence, usually these aren't very sedating, but you might get slight sedation with them. If you do, take them at night. That's usually an easy way to get around that. Weight gain is not substantial. However, sometimes people who have been experiencing loss of appetite because of their depressive symptoms might rebound weight gain because they're actually starting to eat more because they feel better. Bleeding, there is some evidence that says that SSRIs can inhibit platelet aggregation to a lesser degree. So I don't think this is a clinically significant issue, and we don't really care about this. Not like you wouldn't prescribe somebody aspirin or Plavix if they had an indication for it, if they're on an SSRI. But if you type in an SSRI into like an electronic medical record or prescribe it to somebody, and it cross-references the side effects, you very well might see bleeding risk pop up as something you have to clear as an interaction. So just in case you see that, again, it's not thought to be very clinically significant, but it is. And I did talk about the anticholinergic stuff already. Okay, citalopram, I'm going to go through the drugs. There aren't really preferred drugs here, so it's basically like start an SSRI. Whatever one you want to do, well, that's sort of up to you. Some general advice for starting SSRIs that's not necessarily guideline based, but first of all, you'd want to look at the side effect profile. So if you have somebody who already has maybe bowel issues, probably avoid something like sertraline. But otherwise, something people do a lot is they see if you have a sibling or a relative that has been treated for depression in the past, and if they responded well to an agent, they will try that same agent. That's a really common strategy psychiatrists use to treat people with mental health diseases. So that's one way we can look at starting SSRIs. But otherwise, there are some more common ones. And I would say citalopram and probably its cousin, S-citalopram, are the most common ones. Citalopram was Celexa and S-citalopram was Lexapro. They're both generic now. Citalopram was a really popular one, and now Lexapro has kind of taken over its throne as the most popular. So S-citalopram is a really, really common SSRI to start people out on. The really nice thing about these drugs is they basically have no side effects. There are some 2D6 inhibition. Citalopram does prolong the QTC interval a little bit, especially with higher doses. So they've made some recommendations to not ever dose it above 40 milligrams and to not use it in patients over 60 who have 20 milligrams. In patients over 60 with doses higher than 20 milligrams. Now, this has been kind of controversial because what if you had a 65-year-old person who's on 60 milligrams of citalopram? It's working great. Would you stop it? No. Be reasonable, right? So we can do a QTC. We can do an EKG. Do a QTC. We can do an EKG and measure their QTC and see how significant this is. But generally speaking, I don't really care about this from a clinical perspective. I mean, it's a good thing to know about the drug, but you aren't going to see somebody get like extremely prolonged QTC from just citalopram. It's just not going to happen. They're going to have something else on board as well, just like with all real QTC prolonging agents. Hopefully you guys are getting that trend. The big deal comes when you stack them up. Certainly if you overdosed on citalopram, I would monitor QTC and do an EKG and check that periodically. But other than that, I don't really get too concerned about this one. S-citalopram does prolong the QTC, but to a lesser extent, and it doesn't have any dose restrictions associated with QTC monitoring with it. So S-citalopram, really, if you're looking for the cleanest SSRI, that's probably it. Now, is it going to be perfect for everyone? No, but it does have a pretty nice overall side effect profile. Other ones, and again, these are all commonly used. Sertraline is Zoloft. Again, most GI side effects. Fluoxetine is Prozac. Fluoxetine is kind of nice because it's got a 3 to 4 day half-life. So if you have somebody who struggles, maybe misses a dose here or there, if you miss a dose of Prozac, you have no real loss of blood concentrations. I mean, slight blip versus if you're on, for example, paroxetine, it's got a very short half-life. And if you miss one dose, you can actually feel really uncomfortable within 12 hours after stopping that. These all have various CYP-related interactions. Not a huge deal overall. Might come up if somebody's on something that that's metabolized by that pathway and it's really important. But overall, it's not a huge deal. I just put these in here so you can look at the the differences. Fluoxetine and paroxetine both have the strong 2D6 inhibition, so that might come up if something's metabolized that way. But otherwise, I'm not too concerned about that generally. Paroxetine is very anticholinergic and it's very sedating and it's got a short half-life. It's my least favorite SSRI for those reasons. It's just there are better options out there. There is a Paxil extended release version that's on the market that is I believe that's generic now too. So if you are going to prescribe paroxetine, so let's say you had a patient, you wanted to start them on an SSRI and they're like, gosh, my mom had depression and she was on Paxil and it always worked really well for her. You might consider starting it. There's nothing wrong with that, but I would definitely use an extended release formulation to hopefully mitigate some of these symptoms and just know that the patient might not tolerate it well. I also would say to avoid Paxil in the elderly just because of the anticholinergic effects that'll be more compounded in elderly patients. And with elderly patients, we're oftentimes adding low-dose SSRIs kind of later in life to combat some of those almost natural depressive-like symptoms that come with sort of the aging population. And in this case, this is one I would probably avoid if you can. So that's, again, my least favorite option out there. Whoops, let's see, next slide. Some other ones. These ones are, so those are really the big five. There's really 5 SSRIs, so, citalopram, S-citalopram, sertraline, fluoxetine, and paroxetine. Then there are a couple other odd ones. Vilazodone is a new one. It's not generic, but it's got basically the same mechanism as other SSRIs. It's useful. I see fair amount of use in this, and I think it's one of those medications that's like, well, we've tried other SSRIs and it doesn't really work, so let's try this one. Fluvoxamine sounds a lot like fluoxetine, right? Fluvoxamine, or Luvox, is the oldest SSRI. It was one of the first ones made. It's kind of like Paxil but worse. It's got a lot of drug interactions, a lot of side effects, sedating, GI-related things, headaches. Some people do think fluvoxamine is a little bit more of a potent SSRI than the other ones, which maybe leads to why it has a bad side effect profile. So sometimes you might see this used and you're like, why is that person on fluvoxamine? Well, because they probably tried a lot of other stuff and nothing works, so they go to these. Sometimes that's how mental health works. Usually we try the new drugs that have better side effect profiles. If that fails, we start to go back into the old stuff, or the middle ground, the stuff that's sort of not that old but's been around for, like Prozac, for example, has been around for few decades. So it's not a new drug by any means, but it's still new compared to fluvoxamine, which is a really old drug. So with mental health, sometimes they dig back into their archive of, okay, what worked in the past, and yeah, let's try it because nothing's working for this patient right now. Otherwise, it's definitely not a go-to SSRI that people are going to give, for a patient starting out with depression management. SSRIs have a black box warning. Specifically, it says antidepressants increase the risk of suicidal thinking and behavior in children, adolescents, young adults 18 to 24 years of age, and with major depressive disorder and other psychiatric disorders. Consider risk prior to prescribing. This is something that comes up occasionally, and interestingly, so if you read these follow-up bullet points, the studies don't show an increased risk in patients over 24 years old, and actually show a decreased risk in patients over 65 years old. The reason is, the theory behind this is that if you start an SSRI, it takes a couple weeks to actually get that antidepressant effect. However, that increase in serotonin in the brain can help you get some energy and maybe make you feel motivated to go out and complete some tasks. So that might be good in some people, but in maybe a more compulsive young adult who already maybe had some suicidal tendencies, one of the theories is that somebody could say, well, now I actually, I was really depressed and I was thinking about suicide, but I was so depressed I couldn't get out of bed. I couldn't even consider doing something because I didn't have any desire to complete a task. And now it's like, well, I'm still thinking suicidally, but I have some more motivation to complete some of these plans that I've been thinking about. That's the risk there. It's not a reason. It's definitely not a reason not to use SSRIs. I don't know if I said that right, but you guys get the point. You can use SSRIs in children and adolescents. In fact, they do a lot. I would say S-citalopram is the one they start fairly often in kids, and a lot of them actually have approval in children as well. So there are there's actually been clinical studies done in kids with antidepressants, but this is a risk. So it's probably a good idea just to talk to parents about that, make sure they understand that this is a possibility, make sure their children have good support networks during the initiation phases of an SSRI. Discontinuation syndrome is something that is it's kind of, just think about it like withdrawing from the drug, but it's a little bit different than that. Basically, it's for people who are abruptly stopping an antidepressant, not just SSRIs, basically any psychiatric medication. It's going to have somewhat of a similar concept behind the cessation of it. So symptoms are going to be usually GI related, dizziness, things like that, maybe some sleep disturbances. But psychological symptoms may emerge. I think about it like whatever you're trying to treat with the drug is probably going to come back in full force. So you could get really extreme depression. More often, patients are experiencing just feeling uncomfortable, restlessness, agitation, panic attacks, being irritable, those types of things. So it can obviously doesn't sound good. So the thing to remember with this is drugs with short half-lives have higher risk of discontinuation syndrome. So the two big ones are paroxetine, which we already talked about, and also when we talk about SNRIs, the drug venlafaxine or Effexor has a very short half-life too. Those are kind of the two very notorious ones at causing this. Longer drugs, longer acting drugs like fluoxetine, again, don't really have much of a risk with this, but certainly once the drug's out of the system, you could be at risk for some of these symptoms. Serotonin syndrome is something you'll hear is associated with any serotonin drug. It's extremely rare. It is deadly. Not in all cases you can treat it, but it's difficult to treat. And it usually requires multiple serotonergic agents. So somebody's not going to get serotonin syndrome from taking one SSRI. I don't actually think that's physically possible, but I don't even think it's possible to overdose on SSRIs and get serotonin syndrome. I think that would be insanely rare. You have to have a combination of things going on. But if you do get serotonin syndrome, what happens is you get CNS excitation, so hyperreflexia, clonus, rigidity, and respiratory failure. You get altered mental status, anxiety, agitation, and autonomic excitation, which causes hypertension and fever. And so really the thing here is we try to avoid adding lots of serotonergic agents on top of each other. So that's one thing just to keep in mind when we talk about these other drugs that have some serotonin activity but also have mixed mechanisms, like what can you use together? Well, ultimately we only want, if in an ideal world, you only have one serotonin agent on board at once, but sometimes you do combine things for various reasons, and we'll talk about those here. Okay, SNRIs are selective serotonin and norepinephrine reuptake inhibitors. So these do the same thing as SSRIs, but they block the reuptake of norepinephrine as well. I think of norepinephrine in the central nervous system. We've talked about it a lot as a pressor in the peripheral vasculature, but in the central nervous system, I think about it maybe more associated with kind of energy and motivation type mood changes that will affect it. Venlafaxine was the first SNRI. It's basically an SSRI at low doses, and then once you get into higher doses, you get some of the combined norepinephrine effects. It's got a very short half-life, like I just said, so the discontinuation syndrome is a big problem. Some people report stopping Effexor, and they get these things called brain zaps, where they they feel like their brain is, I don't know, I feel like it must be some kind of like electrical feeling sensation in their brain. But that's pretty common that I've heard from a lot of different patients. And then maybe cardiac issues at high doses or overdose due to the norepinephrine effects. It is more dangerous in overdose than standard SSRI because of that norepinephrine effect. You have hemodynamic blood pressure changes and cardiac effects. However, there are some improvements over an SSRI potentially, so less sexual dysfunction, especially at higher doses. People don't lose libido quite as much with an SSRI. It's generally more activating, so if somebody's struggling with sedation on an SSRI, this would be maybe a good alternative to think of. There is a medication called venlafaxine or Pristiq, which is essentially just an enantiomer of the drug. It's an alternative, and it is really no different, but it's, again, one of those newer drugs that falls into the category of, okay, we're trying the current drugs that are cheap and generic, and let's try a more expensive one if those ones don't work. So otherwise, I don't really have much to say about Pristiq. Cymbalta we've talked about already for pain. It is an antidepressant, and you can use it for antidepressants. However, of course, you've got the pain thing too, which makes it handy if you have somebody who has pain or any type of pain syndrome, and we're talking about it for anything, so neuropathic pain, fibromyalgia, osteoarthritis. So that makes it versatile as far as using it for two conditions at once. And you have, a number of different things associated with it, but overall it's pretty well tolerated as far as maybe some renal restrictions and some metabolic things, but otherwise it's a very well tolerated medication. These drugs, don't worry about these. I won't test you on them. They're very odd and not used very often. They're kind of like SNRIs, but they have some different activity. MAOIs, we'll talk about here in a second, are monoamine oxidase inhibitors, so don't worry about that. Or we talked about those with Parkinson's disease, but we'll talk about them a little bit more here. Drug effects, the adverse drug reactions aren't good with these. So these are, again, kind of like a salvage therapy option. Like, all right, what have we tried? We've tried every other class. Let's maybe consider these. Trazodone is a really common medication. It's most often used for sleep. At low doses, it's very effective as a sedative. You need much higher doses to get somebody to get antidepressant effects from it, and some people just don't tolerate it all that well. It's kind of anticholinergic, and at high doses, even if you take it at bedtime, you can still kind of have people report like a hungover sensation in the morning with it, kind of groggy. It can also cause some orthostatic hypotension. There is a very rare chance it can cause priapism in men, but it's, again, really rare, but certainly maybe something worth mentioning. And then there is an extended release product, but I don't get why you take trazodone during the day. It just doesn't make any sense. So even if it is ER. So again, trazodone, we'll talk about this briefly when I mention sleep disorders as an option, but that's really what I'd remember about trazodone, as it's a super common sleep aid. Not really a very common antidepressant, but technically is an antidepressant. Bupropion is a very popular drug that is sort of on its own island from a mechanism perspective. It's a dopamine reuptake inhibitor. It has some maybe effects on norepinephrine too. However, it does well, as far as I can tell, it's really the only drug in its class, which is interesting. There's not a lot of them like that. Its seizure risk is the biggest concern here. So people with epilepsy or low seizure threshold to begin with isn't going to be something somebody we're going to give bupropion to. An overdose, that's what we're concerned about. Some things this is used for. First of all, it's a standalone antidepressant. It can be used by itself. But the more common thing it's used for is to add on to an SSRI regimen. So somebody's on an SSRI, they're improving, but they've lost their libido. This can be added to improve sexual function. It's a fairly effective way to do that, and you get the added benefit that it's an antidepressant as well, so you might get some additional therapeutic benefit from it that way. It's activating, so that means not sedating. It's so if somebody's struggling with sleep or excessive sleep, it might be worth trying. There's other indications for bupropion too, so specifically for seasonal affective disorders, smoking cessation, gambling addictions, and maybe even other addictions as well. Think about the dopamine effects there with some of those different diseases, and that dopamine, we think about the body's reward system and pleasurable effects, and so this is a way to mimic that on a smaller scale. Mirtazapine is Remeron. It's got an interesting mechanism, but it's at its core, it's a serotonergic agent. It also has some alpha-2 antagonistic properties, which can also affect the release of various neurotransmitters. Mirtazapine is another drug that's actually used as a sleep aid, and interestingly enough, they've shown that higher doses of mirtazapine cause less sedation. So if you use it for sleep, stick to a low dose. Doesn't cause any sexual dysfunction, as minimal GI disturbances. However, it actually stimulates appetite, so people might gain weight if they take mirtazapine. So it's got some interesting functions there. And this one, even though it is serotonergic, you can add it to an SSRI regimen. It's just maybe a little bit frowned upon. Try something else first, but certainly an option. I shouldn't say frowned upon. That's probably a bad word. Maybe, again, try a different combination before I'd go to mirtazapine plus an SSRI, but it's certainly something that could be done if you thought there was a good reason for the addition of the medication. It can be used alone as a antidepressant, but it's often used in combination with other things. Very, very common sleep aid at low doses. Vortioxetine, or Trintellix, is a new drug that is a serotonin reuptake inhibitor, and it also has some serotonin direct agonism and antagonism in certain areas of the brain. How it all works is beyond me. I'm guessing you're trying to shunt serotonin from certain areas by blocking it and activating it in some areas. I don't know exactly what the theory is. But the point is, this drug's marketed as this new drug with a different mechanism, but at the end of the day, it's pretty much an SSRI with a few new bells and whistles, and ultimately has the same side effect profile essentially. So this falls in that pool if you're sorting things for your exam purposes or for real life or whatever. This is one of those newer drugs that, again, we would try after we try some of the current old fail-safes, like our basic SSRIs, our basic SNRIs are going to be kind of our first line, and then some of these newer ones like this one, and then Vibrad would fall into the category as well, or Vilazodone. All right, some older drugs I'll touch on very briefly. You probably won't be prescribing these for depression, but maybe for other things. Tricyclic antidepressants, amitriptyline, nortriptyline, they aren't really used for depression anymore. Basically, they're effective, so don't get me wrong, they work, but they're basically just SNRIs with a little bit more potency and some other effects as well. There are very deadly in overdose. These are some of the most, I think about putting my tox hat on, and this overdose probably scares me more than any other overdose of any medication that somebody could easily get their hands on, because there's really nothing you can do. Essentially, they're antiarrhythmic in high doses, and so they block sodium channels, and they can cause some significant central nervous system effects like seizures. So you've got somebody with an arrhythmia and who's seizing, and eventually they go into heart block, and there's no reversal agent. You can't give them something to remove TCA. You can try some things. We'll talk about that during talks a little bit more, but these drugs are really concerning. So for that reason, people who are depressed and might be contemplating suicide shouldn't be prescribed these. In fact, when these first came out, they were effective, but there was documented cases of people getting like 7 days at a time, and that's it, because they didn't want people to have enough to be able to kill themselves, because even a month's supply, if you took it all at once, would be enough to kill most people. So these are very deadly in overdose, and we don't use them very often in the mental health population because of that. However, again, put it in your bucket of old drugs that work and maybe work better technically than the new drugs, but come with a lot of baggage, right? So yeah, that's all I'll say about TCAs. I will mention that I think I brought up TCAs a couple other times. So neuropathic pain, we also use TCAs in low doses for sleep and migraine prophylaxis as well. So again, non-depressive related treatment options there. Monoamine oxidase inhibitors. I don't want you to know what these are other than just understanding that they exist. They're super rare to see them used. They're the oldest antidepressant class. Some people think these are actually the most effective antidepressants on the market. However, again, tons of baggage. So we talked about the specific agents used for Parkinson's disease. The big problem with these is foods have tyramine in them, which leads to hypertensive crisis, and monoamine oxidase breaks down tyramine. And if you inhibit that enzyme, you get some nice effects like increasing serotonin and norepinephrine in the brain, but you also increase tyramine floating around, which can cause hypertension, and which can increase. Well, the tyramine's a precursor to different neurotransmitters, right? So I should just show you the picture. So tyramine gets made into multiple things, tyrosine, and then ultimately downstream effects. It's a neurotransmitter precursor, right? So it not only is responsible for being a basic building block for neurotransmitters in the central nervous system, but also beyond that. So if you inhibit monoamine oxidase, the point is you can end up with increased norepinephrine and things like that floating around, which can cause a hypertensive emergency. So people on MAOIs have to watch their diet pretty well. I say all the good foods like beer, wine, aged cheese, and meats, everything people like. And these also have the highest risk for causing serotonin syndrome. In fact, when you take MAOI, you have to make sure there's nothing else serotonergic on board. If somebody's on a SSRI and you're going to switch them, you have to wash them out for a couple of weeks before you do that. And I'll talk about that change in a little bit here. That's pretty much it for the drugs. Let's talk about some of the options here, pharmacologic and non-pharmacologic, as far as what we're going to use as treatment pathways. First of all, non-pharmacologic options, or we could consider this sort of the CAM category, complementary alternative medicine. Lots of things have been studied to varying degrees of success. Most success is shown in people with mild to low depressive symptoms. So that's where some of these alternative things. It doesn't mean you can't recommend them to people who have major depression or severe depression, because it can be a great adjunct, but those people are probably going to need pretty intense psychotherapy and medications in addition. So the point of showing this is these are rarely going to work as monotherapy for the bulk of patients we see with depression. Again, mild symptoms, sure, but for the most part, you're going to have to do some more than that. But again, great adjunct therapy. So exercise, again, for mild cases can be very effective. Again, should be considered an adjunct for all patients. Comorbidities, are they having anxiety and sleep disturbances? Those things should be addressed. Supplements, there's not really any good evidence of supplement use. There is a decent study with vitamin D that shows that vitamin D plus fluoxetine was better than fluoxetine alone, but that hasn't really been replicated frequently. But then again, no one really studies supplements because there's no money in it. St. John's wort has been shown to be somewhat effective for mild serotonin. However, it is a heavy drug inducer of the CYP system, cytochrome P450 system, and it's got serotonin syndrome risk associated with it too. Dosing isn't standardized because it's an herbal supplement, so I wouldn't really recommend St. John's wort unless you had a patient with mild symptoms who was interested in trying an herbal product, but I wouldn't ever recommend it to somebody directly. Light therapy could be efficacious for a seasonal affective disorder. Doesn't have the best evidence for standard depression, but again, if somebody wanted to try it in adjunct to other treatments, just make sure that if somebody does have severe depressive symptoms, these aren't really the core answer. So don't be like, oh, you can go home and use your light lamp and that's going to make you less likely to commit suicide. Probably not. If they're at that point, they really need some heavy intervention, which is going to be, again, psychotherapy plus a medication in most cases. And again, psychotherapy is a huge component of managing mental illness, right? All right, sorry I crammed a bunch of stuff into this slide. So timelines here. So basically with depression, you have your acute phase, weeks 1 to 2, increase energy, improve sleep, improve appetite. Weeks 3 to 4, improve mood. And this is taking medications, right? So sorry, I should say medicating depression, or maybe change that slide. But anyway, you guys get the point. Week 4 to 8 should be at your dose at that point. Patient may be experiencing relief, and then continue your treatment and reevaluate for optimization at week 12. Continuation after your first episode, treatment usually considered for about 4 to 9 months after response is achieved. After that, sort of up to you whether you want to have the person try to stop their medication or not. Probably depends on how significant the first event was, what else they're doing in their life, have they relapsed before, lots of different variables. Risk of relapse, 20 to 85% will relapse without continued phase of treatment after initial response. So again, that's where, do you cut them off at 9 months or not is a big question mark, and what exactly, why would you want to do that? And some patients might really want to get off their meds. Other patients might be like, no, please keep me on my medication. Time to recovery, 5 months with adequate treatment is usually about the average time to recover. 50% of patients who have a single episode will recover without recurrence. And there's some definitions of recurrence down there as well. Even though the STAR-D trial is kind of old at this point, I still think it's worth bringing up. It was one of the biggest trials and one of the most landmark trials out there, where they looked at a bunch of patients with depression and randomized them into different treatment option groups. And here's essentially the breakdown of it. So this looks really confusing. But so what they did was they took all their patients, and some people got kicked out right away, but then they put them on citalopram. And some of them left because of symptom resolution or whatever. Other ones went to follow-up because of not complete symptom resolution. And then they got randomized into further things. So you can see here what they did was they tested people, and they in different groups. So they switched people to bupropion, switched them to sertraline, so that's just an SSRI switch to venlafaxine, added on bupropion. They added on buspirone, which we haven't talked about. That's kind of a serotonergic medication that's used for anxiety. It's sort of an oddball. And then they added on cognitive therapy. Or they just took them off the drug and switched them to cognitive therapy alone. And then you can see things went further from this category. The cognitive therapy group kind of had a different pathway. Eventually, they looked at adding things like tricyclic antidepressants or T3 augmentation, so putting people on liothyronine, which we've talked about already, putting people on tranylcypromine, which is a MAOI, or venlafaxine plus mirtazapine was kind of like their tier 4 category. Now, again, this is old, so they didn't have access to a lot of the drugs we have now. Well, I shouldn't say that. There's some drugs that are used commonly for depression, adjunct, that they didn't really have access to. So take this kind of with a grain of salt, not like this is your treatment Bible, like, oh, I should put somebody on this and this and this. It's not really the way it is. Basically showing the options that are sort of standard out there. So if somebody doesn't respond to your SSRI, the idea here is you switch them to another SSRI, you switch them to an SNRI, you switch them to a bupropion, you add bupropion, you make sure cognitive therapy probably should be on hand at first, and I'll show you a better updated version of something like this here in a second. So anyway, just the STAR-D trial was one of the first ones out there that said, let's look at all these patients with depression. How are we treating them? There's all these drugs on the market. They're all expensive. They were all kind of brand name at this point in history. So how do we best approach our patient care? Adjunctive therapy kind of anything goes. I'll talk about some guidelines here in a second. A lot of them aren't FDA approved. Some of them are. Anyway, I'll skip that for now. And then just know that there's a lot of things are treated similar to depression. So generalized anxiety disorder, OCD, both SSRIs are first line. However, the dosing can be somewhat different. For example, in OCD, the SSRI dosing is quite a bit higher than in depression, at least the final goal dosing. So just know that sometimes that changes, but generally speaking, you start at the same doses and work your way up. You just might have an end goal that's a little bit different than for depression. Okay, this is a copy of some of the guidelines out there that look at treating depression. So, for example, APA, the Canadian group, I can't remember what that stands for. But anyway, you've got psychotherapy plus pharmacotherapy for most of these, right? It's pretty standard. Psychotherapy, pharmacotherapy. Psychotherapy may consider pharmacotherapy. So basically they're saying everyone starts with psychotherapy plus pharmacotherapy, which they're defining as SNRI, SSRI, bupropion, mirtazapine, or vortioxetine. So they're basically saying you could be on any one of those options as a first-line choice. So nothing really different from what we've talked about. Second line gets really tricky. You can see that this group recommends alternate SSRI, SNRI, TCA. This one augments with various different things as well. Doesn't really specifically get into it. This one says alternate same or if different class plus minus psychotherapy, but you already should have had psychotherapy on board. So I guess they're saying if you didn't add it, make sure it's there. I don't think it's uncommon for somebody maybe to report with mild depressive symptoms and say, we'll just start a medication, and then they maybe don't follow up or take your recommendations and never go to counseling or anything like that. So making sure, again, you reinforce that. Interestingly enough, so this one, augment antidepressant with antipsychotic. The Canadian guidelines, which by the way are the newest guidelines out there, the most recently updated, actually say to add an antipsychotic on first line. That's interesting because that's been done quite frequently. And we'll talk about antipsychotics in the next lecture group, but they've gotten a lot of use as treatment-resistant depression augmentation agents. And these are the first guidelines that say, you know what, most of the guidelines recommend them at some point, but these are the first ones that say, you know what, why don't you just go straight there after your first one? You can see here, augment with FDA-approved antipsychotic is an option in the APA guidelines, but they say that's the, kind of their preferred thing to try, which again is interesting, assuming you responded a little bit. So this question comes up a lot. Well, what do you do if, do you always just get rid of the SSRI, or do you keep the SSRI on? And it depends on the response, right? How well did they respond? Partial, no response. Some of these break it down a little bit more. So if they're getting some response from the SSRI, you're probably going to want to keep it, assuming the side effects are okay. If they aren't, then if they aren't getting any response at all, don't keep the drug. All right, this is a nice chart that shows you kind of the initial treatment. So you could go psychotherapy, and some patient might say, you know what, I just want to try the complementary alternative techniques, so I'm going to do exercise and diet and focus on sleep hygiene and go to counseling, and I don't want to take meds. Okay, well, that's where you'd go, and then if that doesn't work, then you kind of go back into this category. Otherwise, your first line pharmacotherapy agents are there. 4 to 8 week trial. Suboptimal response, partial response, or response. Response can be measured, and so that's where the that's where the PHQ-9 comes in handy. And there's other screening tools as well for depression, but that's kind of how you would objectively measure your response. You're like, all right, how many points are you scoring on these tools? What was your baseline? How are you doing now? That kind of determines whether your response is partial or suboptimal or you got full response. And then, so after you try these initial ones, you're going to go down to here, depending on what's going on. Alternative antidepressant, same, different class. Augment antidepressant, kind of similar to what we've already talked about here. And then consider psychiatry referral, if you haven't done that already. And then changing some of these things out, trying some different meds. So that's really it. And again, it's sort of up for interpretation on what the best strategy is. There's some evidence for some of this, but there's also a lot of it's theoretical and anecdotal. So really, I'm as far as an exam perspective, I'm not going to give you a super complicated case, but I do want you to kind of be thinking about how you might change it. So I try and focus on sort of the second tier of things. So start with your SSRIs, SNRIs, and then focus on how would you augment therapy with a patient who wasn't responding. And I wouldn't give you like somebody with a 20 med history to try and figure that out. That's a nightmare. But that's kind of the goal. I'm hoping you guys can, or for my goal for you guys, that you guys can take away from this. Switching between your agents. If you switch from an SSRI to SSRI, you can switch at an equivalent dose. You can also do that SSRI to SNRI. Everything else you're going to want to cross taper, whatever you're changing to. So that's just the thing to remember. People are like, well, how do I go from this to this? And it's a common question that comes up. But yeah, you could, if you're worried about it, like if you're like, I don't really want to go from dose to dose with these, you could cross taper them. But the only thing to remember is that SSRI, SRI can go one to the other, no problem. MAOIs, you want to wash out anything. So if you're stopping an MAOI and starting something else, you want them to be off of it for 2 weeks. This makes MAOIs really tricky because if somebody's to the point where they're on an MAOI, they probably have pretty severe depression in this day and age, and we've actually had people who have had to be hospitalized during their washout because they're at high suicide risk because we're worried about having no drug on board whatsoever with them while they're trying something else, or washing out from another antidepressant before they can start their MAOI. Depression and pregnancy. So mild to moderate symptoms in pregnancy, psychotherapy, cognitive behavioral therapy, antidepressants are usually used during pregnancy. Pretty much all the SSRIs are used during pregnancy. There's no real contraindications. And then we usually use pharmacotherapy as for all severe patients. The older ones have more data, so like sertraline and citalopram tend to be preferred, but plenty of people take escitalopram. Paroxetine, just like with anything, has a few more risks, but can technically be used. Fluoxetine is the only one that I've read is recommended to not be used. You could technically do it, and it's a risk-benefit situation. So if the patient responded well and has had severe depression and you don't want to take them off of it, it's probably not worth the risk to the patient. But if you could switch them, that might be ideal. Fluoxetine's half-life means that it might build up in the developing fetus a little bit longer and give them higher levels of exposure than other medications. Escitalopram, being newer, lacks data, but is widely used in pregnancy, is likely just fine. Venlafaxine, bupropion, tricyclics all have pretty good data. Most of them don't have solid studies behind them. A lot of it's retrospective. So we're like, well, this group of people took these medications during pregnancy and they all did fine, so it must be okay. That's basically what we do with pregnancy because we don't generally do studies on pregnant women due to ethical reasons. All right. Lactation, again, there's some information here. This is a big deal just specifically because of postpartum depression. So really common for women who've never had depression to start an SSRI postpartum because they're experiencing depressive symptoms. And essentially we look at we'll talk more about lactation concerns and how we approach that. But really the bottom line is you look at how much milk is going to get, or how much drug is actually getting into the milk and how much the infant could possibly absorb. The lowest milk excretion are sertraline and paroxetine. Highest excretion are fluoxetine and citalopram. However, we don't switch, so that's all well and good. So if you're starting somebody on a drug after they were pregnant, sertraline might be a good choice. But if they're on escitalopram or citalopram during their pregnancy, it's probably not worth switching them because they've been stable. What's the point? It's probably not going to be a big deal. There's not really any information that says that infants exposed to SSRIs, it really matters at all. So that's the moral of the story there. Discontinuing antidepressants. Abrupt discontinuation is not recommended. We talk about discontinuation syndrome. You could tolerate it better with certain drugs, but again, we should taper them. If you're going to stop somebody like at that 9 to 12 month mark, 2 to 4 weeks is usually an adequate taper for antidepressants. And then I threw a case in here, so if you guys want to pause this or review it, but I'll go through the case now, so it's there for you. And again, this is an example of some questions I might ask, a little bit higher level than what I might ask on a test, but here we go. So this is JJ. She's an 18-year-old female college student, been given diagnosis of first episode of major depressive disorder, presents to the student health clinic for initial treatment. Symptoms include unintentional 10-pound weight loss. significant psychomotor retardation, and constant feeling of hopelessness. Current BMI is 28, and laboratory values are within the normal limits. Which one of the following is best to recommend as JJ's first-line treatment for MDD? So you've got options fluoxetine, mirtazapine, nortriptyline, and paroxetine. So the answer to this question would be A, fluoxetine. It's because you wouldn't start somebody on nortriptyline or mirtazapine usually. And paroxetine, again, is sedating. It's got poor side effects, and it's just not going to be a good option for the majority of people compared to fluoxetine. So fluoxetine is a good choice for somebody like this. Basic SSRI, no issues with starting it. 2, which one of the following is the most important counseling points to give JJ? A, abrupt antidepressant cessation may also cause a serotonin discontinuation syndrome. B, after initial response, period for continuation of treatment is 4 to 9 months. C, adding routine exercise to lifestyle modifications helps depressive symptoms. And D, the risk of suicidality, is increased, especially during the first 8 weeks of treatment. Okay, so this isn't one of my questions. I took this off of like a review guide, but so it's a little bit more complicated, but it brings up some good points. And I wouldn't ask this question on the exam. It's a little more complicated than that, because all of these kind of sound right? I mean, these are all counseling points you might consider giving the person, because none of them are wrong. But the most important thing to remember for an 18-year-old is think about the most drastic. So the risk of suicidality is a thing I would make sure to mention to somebody, as that they could be at risk for that, because that's going to be the most severe. The other things, all well and good. That's the most important. So D would be the correct answer there. 3, after 8 weeks of antidepressant treatment, JJ presents with less than 20% symptom improvement. Which one of the following is the best step for JJ's depressant treatment? So this is somebody who hasn't really responded well. What could we do, and what's the best choice here? So you have a couple options. We haven't talked about aripiprazole, but that's an antipsychotic. It'll come up in the next lecture. You can add bupropion, change to phenelzine, which is an MAOI, change to venlafaxine XR. So what's your best choice here? So this is a little tricky too, again, a little bit more complicated than what I would ask on an exam, but the thing to think about here is, so 20% response, so their PHQ-9 score is improved by 20%. That's not good. That probably means our drug isn't working very well at all. So in this case, changing drugs altogether is probably the best option. So that's going to be D, change to venlafaxine XR. Even though technically, yeah, you could say, well, let's add something on and see if that works. But at this point, is it worth keeping that fluoxetine? It's not really a huge benefit. Now, what's the cutoff? Again, I don't care. I don't want you to know percentages or anything like that of improvement. I would give you a clear cut, no response, some response, or full response, right? I'm going to give that to you in the exam. But a lot of the guidelines will recommend kind of like a 30 to 50% or window is sort of like that's when you start to consider, well, maybe I'll keep that drug on. But once you're kind of under that, it's sort of, not worth keeping the medication anymore. So changing to venlafaxine would be the correct answer for this one.